Hi, Year 12. So this is your Tuesday psychology lesson, and you'll see that it's also Wednesdays as well, but that's mainly just a video that I want you to watch. So more on that a bit later. Just remind us as well that this Thursday there'll be the live Teams lesson at 12 o'clock, and that's when I'm going to review your end of unit test that you should have done for me up from the attachment topic. Thanks to those of you who've already sent it through. Make sure you do so that I can feed back on Thursday. And then, of course, I'm really looking forward to seeing you all next Thursday in school. And there's a couple of things linked to this lesson which I'll ask you to bring with you on Thursday, where I can actually sit with you and review it properly in person, which I can't wait for. So Tuesday the 9th lesson, building on this cognitive treatments for depression that we started looking at last week. By way of retrieval, this is building on from the Teams lesson. We ran out of time slightly, didn't we, in the final couple of segments. So just pause the video, write down as much as you can remember on the cognitive explanation for depression and how we treat depression. Okay, so just jot down as much as you can, and then we'll review in a few moments when you've had a chance to do that. Okay, so when we're thinking about the cognitive explanation for depression, we know that we're thinking about Ellis's ABC model. We know we're thinking about Beck's negative triad. But actually, what I wanted to see whether you remembered there is not just, sorry, I'm going to flick back to some of these different slides here. So our irrational thoughts, the idea that the cognitive explanation for depression is based on the idea that we have faulty cognitions, these irrational thinking processes, the idea of Ellis's ABC model, you can see there, the idea of Beck's cognitive triad. So all of these ideas that we've explored, the self-schemas, that if you think negatively about yourself, you're likely to have that self-loathing that we know is so common in depression. But also, I'm hoping that you remembered some of the evaluation points that we need to be thinking about. And you've seen this before and probably already printed it out. This is just going back to the previous lesson where we evaluated the cognitive explanation of depression and thinking about this idea that actually depression is a bit more complex than maybe the cognitive approach gives it credit for. And we see this problem of comorbidity, and we see this problem of the extremes of behaviours, and that actually the cognitive explanation, whilst it is very good because it's trying to understand the root of the problem and say you have faulty thinking, let's try and change that way of thinking, it doesn't maybe recognise some of the behavioural origins of depression in some patients. And we'll think about that when we are thinking about evaluating the treatments. Okay, so when we talk about treating depression, we know that we take the two key people, Beck and Ellis, and we look at what they said, therefore, would be an appropriate treatment. If your depression is caused by your irrational, faulty, negative thinking, as Beck says it is, what do we need to do to treat you? And if you have this sort of processing where your beliefs about yourself, the B in the ABC model, Ellis tells us, are causing you to react with depression as a result of an activating event, then what do we need to do to change those beliefs and to dispute that thinking that you have? And so we talked last lesson about the different treatments. So we know they all fit under the umbrella term of cognitive behavioural therapy, but you've got Beck's cognitive therapy, and then slightly different, although there's lots of overlap, you have Ellis's REBT, rational emotive behavioural therapy. Okay, and that last lesson is when you really unpicked those. This lesson, we're going to be evaluating them a bit more. We're going to be looking at, okay, so what's good about those? What are the weaknesses? And we know, because you've seen this before when we evaluated the behavioural treatments for phobias, we know that there's certain key ways, if you like, that we need to evaluate. And you could call it an evaluation toolkit for treatments. So we need to think about how long lasting the treatment is. If somebody has the CBT, does that mean they never suffer depression again? So relapse we talk about. The cost of the economy, the cost of the NHS. Is it worth that money? What side effects? Now, usually we tend to talk about side effects in terms of drugs, But even when we're looking at psychological therapies like CBT, we can still talk about the negative consequences or any issues that might apply. How effective is it, of course? And is it generalizable? Will it work for all types of depression? Will it work for all patients? What do the studies tell us about that? I think that's really important that you learn almost that toolkit of the different ways of evaluating a treatment, as I think I've said to you before. But also, I think it's important to put the question in your mind: if I was told I was going to have a treatment, what would I want to know? Well, I'd want to know what the side effects are. I'd want to know how long it's going to take. I'd want to know if it's going to work for good, or is my illness going to come back? I'd want to know if it's going to work for me. Just because it's worked for somebody else, is it going to work for me? How effective is it? So really, this way of evaluating a treatment are just the questions that you would have if somebody said to you, you are going to have this therapy. So really to save you a job and to help consolidate all of the reading that you might find if you look in the textbook, and it's page 150, 151, I've put it together in the table, and you've seen this before when we did the phobias treatments. And I'll just briefly talk you through some of this, but again, I would suggest you print this out and have it for your notes, because we're evaluating. Now, I've evaluated just generally cognitive behaviour therapy. So remember, that's Beck's cognitive therapy and it's Ellis's REBT. And the exam question would ask you to do that. It wouldn't specify them separately. But there's certain things in here which are more relevant to one or the other. Now, relapse is an interesting one. There's not that many studies that tell us about relapse rates for depression when treated with CBT. The fact that the cognitive explanation tells us that depression is caused by your thinking and CBT changes your thinking suggests that it would be much longer lasting. It's almost a permanent cure, if you like. We know that's not quite going to be the case. Some people will show signs of what we call residual depression, on and off, depressed symptoms throughout their life. And CBT, the evidence tells us, is effective. And it's effective in getting that person back on track. But it is likely that there will be relapse for some patients, and therefore they'll need CBT again. But there might be several years in between the need for these courses of CBT. So it is an effective treatment, and we don't want to take away from that fact. But it would be naive to say that somebody will never, ever relapse, especially if a particular event triggers, something sad or traumatic happens. It's likely to trigger it again for patients who do suffer from depression. Now, when we think about the economy, we're thinking about how much does it cost to the NHS, but also the bigger picture. And if somebody is depressed, we know that it means very often they are unable to hold down a job because of that lack of motivation, that lethargy, that lack of being able to concentrate. And that's really costly, because if somebody's unemployed, they're not contributing to the economy, and they're not paying taxes, they're having to claim job seekers allowance or benefits, welfare benefits. So actually, even though CBT is quite costly to the NHS, more so than drugs in the short term, because it's a number of sessions, often 6-8 weeks of sessions with a trained therapist, that's expensive. In the long run, if it means that person can go back to work, has to stop claiming welfare benefits, doesn't have a lifetime on antidepressant drugs, in the long run, it's cheaper. So we can say that long term, it is a kind of financially efficient, effective treatment. There is a lot of evidence to say it works when we're talking about effectiveness. March did a study where they basically had different groups. One group who all depressed, all diagnosed with depression. One group just had drug treatment. One group just had CBT. One group had both. The group that just had drugs, 81% success. The groups that just had CBT, 81% success, so shows it works as effectively as drugs. The group that had both, 86% success and complete reduction in their symptoms. So it certainly suggests it works as well as drugs, and it works best when combined together. And that's quite interesting for thinking about a treatment plan for patients. There have been some studies, so for example, the Rosenzweig study, another thinking that says, actually, if you take drugs out of it and you ignore drugs for a moment and you look at all the different psychological treatments there are, and CBT is one example, there's very little difference between them all in terms of how effective they are. It might actually be more to do with the fact that the person has someone to talk to, that they build up that positive patient therapist relationship. Maybe actually it's more about that than what you do than the actual strategies of CBT. So that's a bit of an evaluative point as well. How generalizable is it? Well, we can use it on all patients, but is it effective on all patients? No. In the most extreme cases of depression, somebody who really cannot motivate themselves in some extreme cases to even get out of bed, the nature of CBT, it's quite cognitively hard work. You're setting them the homework tasks, you're asking them to have their thoughts disputed, you're having that almost argument with them in the REBT. Someone who's in a really poor, bad state of depression isn't going to be able to engage with that. They're not possibly going to be able to pay the attention that a CBT session with a therapist requires, because we know that's one of the symptoms of depression, that inability to concentrate and pay attention. So in those cases, what would happen is you would give the patient antidepressant drugs first to sort of improve the situation slightly, and then you would offer CBT. And going back to the effectiveness study by March, that suggests that's actually a better plan. But what it does show is that CBT can't be used for everybody. There aren't really side effects as such, but a couple of kind of negative consequences or issues to think about. CBT very much, by the nature of it, is focused on your present and now and looking to the future, because it's about your thoughts. It doesn't spend any time revisiting the past. And some psychologists would say that's a mistake, because depression is kind of rooted in historical experiences from your past, and you need to go back and revisit it. The jury's out on that one. There's not really any proof that that is an essential and effective thing to do. But if you think back to your approaches work and your psychodynamic approach, somebody like Freud or all of the people that prescribe to his theory would say you've got to go back and revisit that thing in your past that you've regressed, that you've repressed, that is stopped you from being able to move on healthily. But there's little evidence to prove that. And the other thing that CBT does is it focuses on you and your thoughts, and that being the thing that needs to change. And it therefore doesn't really allow you to change your social situation that you live in. And it might be, in some cases, it might be that's causing you to suffer from depression. If, for example, you're in a situation of abuse, you're being bullied, you live in poverty or very poor social housing conditions. Really what we need is a treatment that allows the patient to recognize what needs to change and to set about changing it with the support and help that they need. CBT says it's all about what's going on in here. We just need to change the thoughts and then we're fine. And that's not always the case. And so actually, if CBT techniques are used inappropriately, it can cause the patient to lack motivation to change the circumstances that really need changing for them to be able to move on with their life. Because that's what any treatment should do, isn't it? It should allow them to move on. So that's our sort of whistle-stop tour, if you like, of evaluating cognitive behavioural therapy. And I've essentially put that together from the notes that are in your textbook, but you can always read up in your book as well. So just a reminder, just to flash this up there, that's your knowledge organizer for this depression section of the psychopathology topic. So we need to know the cognitive explanation, the cognitive treatment, and of course the behavioral, cognitive and emotional characteristics of depression and what the DSM says. Remember, you have got those different groups. So where I've just said there that in extreme cases of depression, CBT might not work. We can actually refer to that as being major depressive disorder, because the DSM does identify it as different types of depression. World Health Organization tells us it's the biggest mental health disorder, and that it's the one that costs the economy the most money. Now, that was obviously before COVID-19. I think that may have changed now, but in terms of mental health, still the case. So this is important that we get this right in terms of treating, diagnosing, and supporting people with depression. Okay, so by way of a little task, couple of tasks for you to do, in your revision packs that I sent you electronically at the beginning of this topic, you've got your retrieval questions, and I've just picked out all of the ones that are relevant to depression there. And you could highlight them on your sheet and just have a go. You should have already developed flashcards on all of these pretty much, but just use these to test yourself. Quickly, I'm not going to collect these in, but just quickly jot down the answer or say it aloud, get somebody to test you on them. So keep doing your retrieval questions. And then the other thing that I've screenshotted there on the right hand side of the screen, and which I've attached to the email that I've sent you all, is just 2 very short exam questions to consolidate your knowledge on CBT. And so also so you can see the context, what you might be expected to do in an exam. And I want you to have a go at that 4 marker, and then there's just a little multiple choice question and your retrieval questions, and bring those exam questions with you next Thursday. Don't photograph them and email them to me, because just bring them in with you next Thursday and we'll go through that together. Okay, and we'll look at the mark scheme and see exactly what this type of question requires. So that's it for Tuesday's lesson. We're putting our evaluation hats on. We're thinking about how we evaluate the treatment from the cognitive approach for depression. And that kind of brings depression, if you like, to a conclusion. So I'll introduce this now. For Wednesday's lesson, all I'm going to ask you to do on the next slide, and again, I've emailed this to you all, there is a link to a documentary, and it's just over an hour. And all I want you to do is watch that documentary about OCD, some really personal accounts in there, building up a picture of what it's like to suffer from OCD, and make some notes on it. Now, I've suggested, although you don't have to, that you use the Cornell notes strategy, where as you're watching the video, you're recording everything in the main notes section there. And then as you're watching, you create almost trigger words, little memory cues in the left-hand margin. So just one word every so often that just triggers your memory on that particular part of the documentary. Then when it's finished, you create a little summary at the bottom. And that's a useful note-taking strategy that helps with revision, allows you to create flashcards from it. I don't mind. You can use that strategy or you can use the normal just note-taking. But I want you to watch the documentary and I want you to note down what it allows us to sort of understand about the key features of OCD as much as you can. And then on Thursday, next Thursday, I should say, so that will be Thursday the, what date will we be on? 15th? 18th, something like that, 18th of June, we will, I'll introduce OCD properly, and that will be the final part of our psychopathology topic, and we'll look at how we explain OCD, what the characteristics of OCD are, and how we treat OCD. So this is really just a bit of preparation for next Thursday. Plus, I think you'll find it really interesting, because we often talk about people being OCD, but do we really understand what that means? Okay, so this has all been emailed to you, everything that you require. Don't forget to send me through your attachment end of topic assessments, please. And I'll see you all on Thursday at 12 o'clock on your Teams meeting. Take care.